Additional events in the real-life trial. Boehringer Ingelheim recently conducted a third-year review of the 1387 deaths that occurred during the real-life trial, which evaluated the effects of 2 doses of dabigatran as compared with warfarin on rates of stroke or systemic embolisms and major bleeding. The randomized evaluation of long-term anticoagulation therapy was a randomized trial designed to compare 2 fixed doses of dabigatran, each administered in a blind manner with open-label use of warfarin in patients who had atrial fibrillation and were at increased risk for stroke. Dabigatran is a new oral potent and direct competitive inhibitor of thrombin. It has an absolute bioavailability of 6.5%. Its serum half-life is 12 to 17 hours, and it does not require regular monitoring.
Late-breaking news today from the FDA with approval of dabigatran, an oral thrombin inhibitor for prevention of stroke in patients with atrial fibrillation. This has been a highly anticipated new approval and indeed the first approved oral anticoagulant in more than 50 years. Warfarin, as we know, is our mainstay of therapy, but it is a huge headache to use in that it is so variable with the interactions with food and other medications and the incumbent monitoring that is required. Now, dabigatran is an oral thrombin inhibitor that's been studied at 2 doses, 150 milligrams that was approved, and 110 milligrams was also studied in the RELY study as compared with warfarin for prevention of stroke or systemic embolism in patients with atrial fibrillation. At the 150 milligram dose, dabigatran was superior in preventing more strokes or systemic emboli than warfarin. It also had a lower risk of intracranial hemorrhage, which may relate to less excessive anticoagulation with warfarin. But it was seen to have an equal rate of major bleeding overall. Now, interestingly, a lower dose of 110 milligrams was studied, had equal efficacy to warfarin, but was safer, and yet that dose somehow was not approved by the FDA. And so we'll be looking for some answers as to why not. But in any case, the higher dose of 150 milligrams will do a better job in preventing strokes in AFib. Now, there are different side effects. Obviously, bleeding is an issue with any antithrombotic agent. Dabigatran also caused some dyspepsia because it's absorbed in an acid environment, but otherwise was pretty well tolerated in the studies. Now, there is not a need for routine monitoring, and so this will be a big switch if a patient starts dabigatran, where they simply take the medication and get an immediate and steady level of anticoagulation. They don't need to come traipsing back to the hospital laboratory for testing. And so it will be a big change in practice overall. Exactly who will start this and which patients will obviously be sorted out in practice, but is a very exciting new development to have a new therapy that looks superior in efficacy and in some aspects safety than our current mainstay therapy. So stay tuned for further developments in the use of this agent and the FDA label on Cardiosource as we monitor this new approval. I'm Chris Cannon for Cardiosource Video News.
Also included in this review were the deaths of 6 patients who did not undergo randomization and 10 deaths that occurred after the end of the study. This review was conducted to determine whether a concurrent event may have occurred with respect to each death, even though such an event was not originally reported. In addition, all fatal bleeding episodes, hemorrhagic strokes, and hospitalization for trauma were similarly reviewed.
MD Conference Live presents updates from the European Society of Cardiology in Barcelona.
Dr. Connolly, thank you very much for being with us today. We're hoping that you will summarize the key findings from the RELY trial.
The RELY study was designed to test whether dabigatran, a new direct thrombin inhibitor, could reduce the risk of stroke in patients with atrial fibrillation. The goal of the study was to show that one of the doses of dabigatran that were tested was as good as warfarin in what's called a non-inferiority study. In this trial, 18,000 patients were enrolled and randomized to 3 treatments. Dabigatran 110 milligrams twice a day, dabigatran 150 milligrams twice a day, or warfarin. The main result of the study was that both doses of dabigatran were non-inferior to warfarin, having shown that they had as good of results on the primary outcome of stroke or systemic embolism. But in addition to that, we've also shown that the higher dose of dabigatran, 150 milligrams twice a day, reduces the risk of stroke compared to warfarin by 34%, a completely unexpected finding, and one which is sure to have a major impact. So both doses of dabigatran are effective, and the high dose is very effective. In addition, and most surprisingly, in spite of the fact that these are potent antithrombotic agents, they both have lower rates of hemorrhage compared to warfarin. In particular, both doses markedly reduce the risk of intracranial hemorrhage and intracerebral bleeding, and dabigatran 110 also reduced the risk of major hemorrhage. So we have a better antithrombotic agent that is also safer.
Doctor, do you anticipate that this drug will in fact replace warfarin?
I anticipate that for many patients this will become the treatment of choice. For some patients on warfarin who are doing extremely well on warfarin and are having stable blood levels, it may well be possible to continue them on warfarin. But for the majority of patients, it appears that dabigatran will be a better alternative.
Dabigatran, administered at a dose of 150 milligrams as compared with warfarin, was associated with lower rates of stroke and systemic embolism, but similar rates of major hemorrhage.
As a GP, I and my patients have waited a very long time for a safe, effective alternative to warfarin. Warfarin requires enormous changes in the patient's life, and it is a very distressing drug to take because so often they will have worked hard to comply with the drug, and yet when they come back for monitoring, as they have to very, very frequently, more frequently than with almost any other drug, they will be told that something about their diet or their lifestyle has meant that they are putting themselves at risk either of thromboembolic stroke or of hemorrhagic stroke. Here we have a drug which does not need monitoring, which does not need dosage adjustments, which does not require my patient to have a season ticket to live in my GP surgery, and which will allow them to know with confidence that they are being protected against thromboembolic stroke without increasing their risk of hemorrhagic stroke.
They compared 2 doses of dabigatran with warfarin in patients who had atrial fibrillation and who were at risk for a stroke. As compared with warfarin, the 110 milligrams dose of dabigatran was associated with similar rates of stroke and systemic embolism and lower rates of major hemorrhage. The 150 milligrams dose of dabigatran was associated with lower rates of stroke and systemic embolism, but with a similar rate of major hemorrhage. After the inclusion of these events in the RELY database, the effects of the two doses of dabigatran as compared with warfarin on rates of stroke or systemic embolisms and major bleeding were only minimal change.
As Chief Executive of Anticoagulation Europe and as a patient on warfarin, I have been really impressed by the results of the RELY trial. We followed the trial from its initial beginnings and through all its interim results, and I could never have expected such good results. To have a 34% risk reduction in stroke, to have reductions in bleedings, both major bleedings, intracranial bleedings and ordinary bleedings, is absolutely wonderful. And for patients to be able to have all that security and efficacy, and also with a drug that doesn't need monitoring, they don't have to worry about the interactions with other drugs, they don't have to worry about altering their diet. It seems too good to be true, but it's there and we welcome it.
For practicing physicians, the results of RELY are going to be extremely important. They now have an alternative to warfarin, which we have proven is both safe and efficacious and offers clear advantages to warfarin therapy. I'm sure that clinicians will be very excited to be able to use this drug in their patients. I have no doubt that the medical community is going to be amazed at these results. No one has expected that a drug would be able to be superior to warfarin for reduction of stroke and at the same time to have such a favorable safety profile and even to reduce intracerebral bleeding by more than 50%. I'm certain that the medical community is going to look carefully at these results and then take them to heart and start using dabigatran in their patients.